Hello, I'm Donald Macaulay and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Edinburgh and I'm talking to Scott Murray. Scott, you're a very senior academic who's done some fantastic work, but let's bring you back to the beginning. Where did it all start?
It started actually up in Glasgow. I was born, but I went to Aberdeen, where I went to university. I was studying maths. Maths, in fact, was my first love. But I became a Christian at that stage, and I thought I could probably do more good being a doctor. So I changed into medicine, and I studied that. I met my wife, actually, over a dead body. Maybe I shouldn't say that. Up in the anatomy lecture theatre, yeah. After we both graduated, in fact, I then went into GP training. It was one of the first schemes in Aberdeen at that time, and that was a joy. And after that, actually, I went abroad to Kenya to work in a rural church hospital there. The great times of our life. We went out with a wee girl, six weeks old, and we had 7 years there, having a glorious time. A lot of medicine to do, of course, surgical, general stuff, a lot of infections. And these days, there's still leprosy and TB, and a lot of people dying of measles and pneumonia and malnutrition. Family planning, interesting enough, at that time was the agenda that you could get more funding for. And in fact, the population size in Kenya, completed size, was 7.4. And with making that available through area health committees and volunteers, the number actually in 10 years went down to 4.8. So that was promoting health. That was the agenda out there.
What you did was something that many doctors of your generation did, inspired by their own beliefs. Tell me more about the work, because many people wouldn't really appreciate the type of work that you were doing there.
Well, it was I was out there working for the church there, so they looked after you, responsible to them, and the idea is to try to run this rural hospital, and the funding has to be got from patients, which is a real constraint sometimes. So, and after 6 months, I was asked to sort of manage it as well. So there were 5 doctors, 250,000 people, nurse training school, and there were 30 clinics, all within walking distance of local people. And the idea was to help them. And primary health care was the agenda. There was a surgeon from Glasgow at the same time, and he dealt with a lot of the surgery. And it was busy time. It was hard time, but it felt very worthwhile. That at the weekends, we sometimes went to local churches, an opportunity to be there and talk, and we learned the language very well then. That was great. So we still speak actually local Kikuyu, and I go back every year. We've gone back to Africa or some of the countries there, and try to support those. Yes, although more recently I've been out to support to integrate palliative care. So it's health promoting care at the end of life, being born well and helping people die well.
And were your family born out there?
Yeah, well, Ian, who's a surgeon now at Edinburgh as an orthopaedic, he was born out there. His name was called Wenda. Went back actually for the centenary of the hospital opening just last year. And with the midwife's a very small lady, and he's 6'2" now, with a lovely picture, and he knows his name there. And Susie was 6 months old, and then Andrew remembers it best. That's my eldest son now. He's a sports doctor, like yourself. Yeah, it was great. We worked hard, and we had some lovely holidays in the game parks and down at the coast as well. Mm-hmm. So we look back at that time very, very favourably and very formatively.
Well, coming back to Edinburgh must have been a huge contrast.
It was actually. I was offered a job in Morningside, which actually I took because I was there, and it wasn't just quite right. And I think, in fact, after 6 months, the partner said, "I don't think you're cut out for Morningside." So I then left there, and I got a job. I thought teaching education. So I spoke to John Howie, and he said, "Well, if you want to be a lecturer with us, why don't you try that?" So we did that, and he helped him. And he said, "Well, if you're with me, you better do a thesis, a PhD." Or I don't know, I'm not really an academic guy, but I was working in a part of Edinburgh with him. There's an old dispensary there, where Dunby Dykes is a sort of poor neighbourhood nearby, and then there's the mountain and stuff. And we noticed that the folk living in Dunby Dykes, were having a rough time, and I was asking them, what are the main issues you got here? And you know what it was? It wasn't medical. It was they wanted a bus so they could get up to get to the shops. The younger people wanted, areas outside their flats with no dog poo on them. And we noticed the main operation that people were getting at that stage, even then, were actually dental caries. So there were a lot of things. So I'm the doctor who got the bus in there. There's this community-oriented primary care, which actually, as a definition, started out in 1926 by Clark in South Africa, but looking to the community, promoting a community development approach. And because out in Chigoria, we've been teaching to the enrolled community nurses how to help people. Someone from a dispensary might come to you and says, I want a hospital or clinic in my village. And so we have to go, well, how do we know if it's really an indicated thing? The nurses were trained to actually, look around, to observe, to interview people, to see what documents. And these are that's this method of rapid participatory appraisal. So I did one of those. It comes from a development background in dummy dice, and the results were that. And since then, I've used that technique about 15 times, doing different things, like bringing a community development approach to services as well, even in palliative care where they can be done in Africa. Mm-hmm. That was a great time there.
So tell me then about the progression of your academic career.
People with advanced illnesses around there, apart from the deprivation angle of it, unless they had cancer, which was some ways lucky, they weren't having a great deal. And so I had a friend back at Chigoria Hospital. I thought, let's compare, dying. So what I did next was did a study. We interviewed people with progressive cancer so I learned how to do qualitative research at this stage by interviewing, because the numbers were, and we also interviewed people back in Kenya. So we asked them, what's your main problem? We're asking, what's your main problem? Very broadly, and the same word here. And although we're doctors, they just gave it. And the main problem in Kenya, I don't know what you could guess, what you think it might be. It was pain, lack of money. Yeah, Dinam Besha, no money, okay, the pain. Whereas in Edinburgh, it was quite different. It was, it's just me, doctor. It was existential. So basically, it's better in some ways to die in Kenya, Tom Holt, that? Not physically, but all the other dimensions, psychologically, people there. Socially, there's a great support. And existentially, there's believe in God as well. So I wrote that paper, BMJ, it's the first one that they took. And it was good, actually. So that compared, death in different cultures. And that was quite fun. And then from there, we went on looking at the experience of people dying in Britain or in developed countries. Because we realized that actually somehow this idea of equity, the things are inequitable by countries, but by diseases. It's postal code equities, but it's diagnostic inequities. And then so we thought, well, how do we understand the lived experience of people and their carers? What we should do is what we'll do. So I went out to learn, and I interviewed some people myself, employed someone who could, a proper qualitative researcher called Marilyn Kendall, an excellent researcher. And we started listening to people who all told narratives of their illnesses. Yeah. It was great. So we interviewed, and with a series of PhD students, in fact, we actually have covered lots of types of cancers, lung cancer, gliomas. We interviewed people with various heart failure, organ failure trajectory, and some people in the third. And I realized people die in different ways, different diagnoses, different things, but they're sort of grouped. So there's a group actually who die of cancer, which is quite predictable, and people understand that a bit, professionals and even patients. But the organ failure, which is the one that goes up, they have a dip and get better. Yeah, folk don't understand that so much. And it takes a bit long. So that was the typical organ failures, lung, heart, liver. And then there's the more dwindling trajectory, which is the dementia. And so we heard people's life experience, and they were quite different. Like death as a character appears in cancer, but people with heart failure, they're not so worried about dying. People with dementia or frailty, they're not. There's other things that are more important about losing their marbles. So I'm thinking the experiences is different and the services must be different. So we then wrote something on illness trajectories, and over the last 20 years, building on quantitative work by Joanne Lynn in the States, we actually started to describe this. And it's great that we wrote a paper in 2005 about illness trajectories in palliative care. And that one is still, every week, it's great. It's sort of cited as well as read. So I think that's pretty good. It wasn't cited so much to begin with, but now that concept, it's in the general parlance, I think, of general medicines and Davidson's and stuff like that. It shows that dying isn't just a process at the end. It's not just an event at the end, it's a process. Yeah. And I even did an amateur video of actually, because dying is like, actually, what type of dance would represent that? Well, it's like gay gardens. understand it in Scotland, goes through the motions, and it's quite predictable, a good beginning and a good end. So, Domo, what do you think? An organ of failure trajectory, what dance do you think I chose to illustrate this and give a wee burst of music when teaching medical students? It's a tango, you see? A tango with these ups and downs, and people don't understand them, yeah? And the last slow one, that has to be a last waltz, yeah? And so if a person, so you can imagine these things happening. And the idea is that if you know the steps, if you understand the illness, yeah, you're most likely to enjoy dancing and be able to dance. And there's lots of analogies in having, if you've got a carer, like a coach. In fact, I did a wee video, it was called Strictly Come Dying. And I've just updated it recently to include multimorbidity, because that's more like going to a disco where you get different dances like that. So that was illness trajectories, and that was most enjoyable. And we did some serious publications in social science and medicine, a couple of research reports in the BMJ to show that the idea of interviewed triads, patients, doctors, and supported carers, and over time. So that's a multi-dimensional qualitative serial interviews. So that was the background to it. And my mantra, my slide that I really liked is there's 5 aspects of helping people, this early palliative care, because it can help people with all diseases, yeah, as illustrated by the work, yeah. You can help at all times, not just at the end, but early on from a diagnosis, yeah. And there's all settings as well is important, and all dimensions. The all dimensions one in all countries, that's the 5, but I'll stick with the all dimensions because dying is more than 4-dimensional, one-dimensional. Dying is 4-dimensional experience. So as we listen to people talking about their experiences, apart from things out with healthcare, which a lot of people have, they would tend to talk about the physical bit, and then any other psychological issues. And we then saw actually that in each of these dimensions, there is a sort of typical trajectory associated as the illness plays out. So there's a physical one, and then you've got the psychological, social, and spiritual or existential trajectory mapping out. And so in analysis back in 2017, we talked about palliative care from diagnosis, and the idea was to map out in a sort of qualitative way. But actually, we understand that the patients actually understand this as well, quite well. And we've written some patient-centered videos so they could understand that. So the idea is that multi-dimensions. I mean, I got lung cancer 10 years ago, Dom, I don't know if you know. And so it's not a clever cancer to get, of course. But so there's a chance. So that, and what we show with the multi-dimensional cancer trajectories, yes, you're probably physically quite well. But that diagnosis, hey, I'm worried, what's going to happen to me? So there possibly is an existential issue or patient, maybe but worried about it. I mean, and then getting home, so then they feel better, get in treatment, they get home, and there's not a time when folk classically are worried again, psychologically and existentially. And then if it progresses, and then at death. And so we can foresee, using this illness trajectory approach, that, at diagnosis, getting home, and before death, there's these 3 or 4 times when you'd expect someone to have issues. So as a GP, I would say, well, when this happens, at least acknowledge, I have any problems in this dimension, because we can predict. It's nearly a predictive medicine where you're thinking ahead, and if you're sharing and asking the person about that, they will like that. And for instance, a person with advanced illness, they'll say, but they don't want to talk about these things. Well, they don't, but 5% possibly disavow. They don't want to talk about. Most people, 50% at least, if they're given an opportunity, they would love to actually hear what it might be for them, and finding out when to start this palliative care approach. It's hard to know when, and we've done some work on indicators for that. And there was a thing called a surprise question. I don't know if you heard of that. Would you be surprised? And it's a good way. It's like the GP knows, when do you think this person needs it? Because we know prognosis is so difficult. It's like a red herring in some ways, And prognosis, if someone asks you, what's my prognosis, doc? I mean, they're really probably behind that question wanting to understand what's it going to be like for them. It's not just, so thinking prognosis, medical, times, I don't know, I have no idea. They think it's to do with numbers. But really, to know ahead, that's what it means, prognosia, doesn't it? And so the idea is, if you're asked about that, good. In the meantime, well, I don't know the time, but let me tell you how it might be for you. So that was my take on prognosis.
Let me finish off with a slightly different angle, and that's, I've heard you say, when you know you're going to die, it helps you live life more to the full.
Yes, in my experience, it certainly triggers. When death taps you on the shoulder, I think you review things. And the idea with identifying a time is starting to talk about that and sort of sorting it out, facing up to and talking about it. And doing that, and that entails understanding it. And then sort of after that, go on with living. And that's the sort of attitude that we like to take. Just let's understand it. And then the stigma of it all, I think, would go like that.
One of the big initiatives in palliative care, which is a conversation that you opened up in the UK, is the Lancet Commission. That really brought it to the forefront.
Yes, there was a commission specifically on the value of death, which Richard Smith, who you'll know, was leading, and I'd had him up to Edinburgh actually to speak, so that he would really get into palliative care. Anyway, I found that in fact there wasn't a primary care voice at this stage on this Lancet Commission of Value of Death, and so I complained. I ended up going with them to help write the paper there, and. We've talked a bit about palliative care. That's a small part, actually. It's a service, a small part. And the great thing about the value of death, they've just thought of they talk about a realistic utopia. What could dying or the whole end of life bit realistically look like in different countries? And it's what we're now trying to actually work out what it might do. And palliative care services is part of it, but there are 5 bits that's worth looking at. It's about getting equality sorted out. And the last one is actually about valuing death itself, which is a funny thing to say. But if people didn't die, Earth would be a very busy place. And they say that civilization progresses by generations. So there is a value, and the value of accepting dying. We accept birth. Accepting death and thinking about it, and what can we learn from it? How can we grow by dying? How can we actually not enjoy it? But it's such a privilege to help and be with people, towards the end of life. I think and if we understand that, and if the population, we should be talking about this well before people start dying, so that they're prepared.
One of the things that I've heard you say is that we start palliative care too late, that we really ought to start it at a much earlier stage in the conversation.
Yes, I think it's when someone gets a life-threatening illness, they think, it comes as a jar, and that's the time when there is an opportunity to plan or think ahead and prevent suffering. Because if you wait until the classic terminal care in the last week, so you're too late to prevent all the morbidity that may happen over the weeks and months and years. Advanced care planning in Scotland now, on average, in non-malignant people, starts 2 or 3 years before. We don't call it palliative care, we call it anticipatory care, or this year it's now called future care planning. And the idea, if you've got an advanced illness, let's plan for the future, sort ourselves out, and then we'll likely have a better time than if we didn't sort ourselves out. And that is complicated, especially in multimorbidity, and that's the most recent work we've done. But even in multimorbidity, we find you can actually summate the net dimensional, if you want, problem of the different illnesses, and they can all work together. There's usually a main illness that conveys what to do. But even in multimorbidity, the idea of identifying, assessing, planning, and getting on with life after that is the way ahead. And I think that is the message. I would say early palliative care. And that's where it's only GPs, I think, can do that, because they're the ones, specialists in palliative care, never identify people for palliative care. They have to be referred there, and therefore it's the GPs and they need time for this when we're so busy doing other things. How can you have time? And that's why a quick thing like the SPECT, for instance, or the surprise question, or just a mental knowing that you think, yes, I think this person might benefit from this approach, and then go ahead. Because there's not many risks of palliative care. It's not like a drug, you know. Well, if it were a drug, it'd be very popular and it would make the company millions of pounds, wouldn't it? But it's not. It's more complicated. Palliatosin, we sometimes have a capsule, a picture of palliatosin, but again, you know, it's a very complex intervention that I think palliative care, especially early palliative, cannot be randomized. You know, I think the RCT model for doing it, and we have to find neater ways of doing that.
Scott, you've really opened up the whole conversation on palliative care. Your work has changed the lives of so many. Thank you very much for talking to us today.
Thank you very much indeed. Thank you.